Welcome to the Pelvic Health Summit. I'm your host, Hannah Matlock, and we're here with Dr. Allison Shrikhande of Pelvic Rehabilitation Medicine. Today we are here with Gastroenterologist Dr. Jennifer Bonheur, who is in private practice in New York City, and she has a special interest in women's health. Thank you so much for being here today.
Thank you so much for having me.
So one question that we get asked a lot and that we're really curious to hear your opinion on, as a gastroenterologist, what is the connection that you see between GI issues and pelvic floor disorders?
Well, as a gastroenterologist, patients will often come to me with complaints of abdominal pain, and abdominal pain can extend into the lower part of the abdomen, which is the pelvis. So they'll come with complaints of lower abdominal pain, which can be for a variety of different reasons. We often think of pelvic pain specifically as more gynecologic type pain or urologic type pain because the uterus is in the pelvis and ovaries are in the pelvis, and and those are certainly reasons why patients may have pelvic pain. Women certainly may. It can be ovarian cysts or fibroids. It can be endometriosis. Pregnancy, ectopic pregnancies can present with pelvic pain. But as a gastroenterologist, there are lots of other reasons why, from an intestinal standpoint, patients may have pelvic pain. And that can include conditions like diverticulitis, appendicitis, inflammatory bowel disease, irritable bowel syndrome. And so there's a gray zone in the abdomen when you're trying to differentiate causes of pain. And so I have to be able to keep my mind open to the various reasons why they may be and try to differentiate between them to help treat the patient.
And as a gastroenterologist, how do you see yourself fitting into the pelvic health team?
Well, in terms of pain specifically, I'm certainly able to help in differentiating causes of pelvic pain. Sometimes patients come to me assuming that the cause of their pain is actually gastrointestinal, and it's not. So it may be the other way. Often they've ended up in my office first, and they assume that there's something wrong in their intestines or in their stomach. And based on a history that I take from the patient and symptoms that they may be having and an exam or any other tests that we may do, sometimes it's really not. And that's when I have to start exploring other reasons why they may have pelvic pain that may not be as obvious or as easy to necessarily detect on an imaging study or any kind of blood work. And so it becomes part of a team effort really in managing patients that have pelvic pain, first in determining the cause, and then secondly in figuring out the best way to treat them and get them into the right hands when sometimes the treatment is not in the realm of gastroenterology.
And with a lot of these GI issues, often comes chronic constipation. Can you explain a little bit why constipation and pelvic floor dysfunction is so closely related?
Very much, actually, and I think that is one of the, it has been, I think, often overlooked for a long time, the relationship between chronic constipation and pelvic floor dysfunction. Very often patients might think that constipation is a function of something that they're eating or that they're not eating, or that they are concerned that there might be an obstruction somewhere in their intestine to the passage of stool. There are so many different reasons that seem more obvious why somebody may be constipated. When you go through the history, and there are certain key history points that when I hear, I think of pelvic floor muscle dysfunction or pelvic floor dyssynergia as a cause of constipation. You stop and you say, wait a minute, this is just as good a reason as any for a patient to not be able to move their bowels, and I think it's often overlooked. So you go through the process of taking a good history and you do any diagnostic tests that may be necessary, but very often the problem is really just at the very end. So there's no issue with respect to the stool getting through the colon. Diet often can be optimized, but maybe they're doing everything right. And at the moment when a person feels like they need to have a bowel movement or they'd like to be able to have a bowel movement, the pelvic floor muscles contract paradoxically instead of relax, and it creates effectively an outlet obstruction where the stool doesn't pass. Symptoms that patients will describe that make me think of pelvic floor dysfunction in the context of constipation is a feeling that they need to strain to pass a stool. Like they're sitting on the toilet and they know that they have to go to the bathroom, but they just feel like they've got to push. They've got to give that extra strain that feels uncomfortable. Or they have a sense of incomplete evacuation. So they're able to go to the bathroom, they're able to have a bowel movement, but they just don't feel like they're able to pass the stool with the sense of completeness that they otherwise might have felt before, or they feel like they should. And that's really a function of pelvic floor muscle dyssynergia, or a dysfunction in the pelvic musculature.
It's so wonderful to hear you say this, because in our practice we see this every day as well. And we're grateful to have physicians like you to help do the proper workup. As we know, sometimes it's a diagnosis of exclusion. What would be some treatments you would give to patients to help them feel better with the pelvic floor dyssynergia symptoms?
Well, I often partner with pelvic floor muscle therapists to begin with, because I really think that when you recognize that this is a problem for the patient, and this is maybe the root of constipation, for example, and you delve a little bit further into their history, there are often other symptoms that the patient is having besides just constipation that maybe they didn't mention right off the bat, or maybe they were a little too uncomfortable to mention, or maybe they didn't even realize might have been connected, that end up being really well managed by a team of therapists that are experienced in managing pelvic floor muscle dysfunction and dyssynergia. So from a constipation standpoint, as a gastroenterologist, I make sure that patients are optimizing their fiber intake and bulking up their stool to give them that sense of weight of their stool, and make it easier for them to have a complete bowel movement. And very often you'll find that patients are eating fiber, they're having a salad for lunch, but they're not really having the 25 grams of fiber that they might need in a day, or they might not be balancing the soluble and insoluble fiber as well as they should be or could be, because they don't know. And so I go through just the diet and lifestyle modifications that I think are simple enough to optimize, or maybe not so simple, but worth the conversation, because it's a much more sustainable treatment, in my opinion, rather than relying on medication or supplements to help them go. Sometimes I also recommend, very often I may recommend, that they raise their feet off the ground when they're on the toilet. So kind of that concept of a squatty potty.
Yes.
And, but it doesn't have to be a squatty potty. It could be a short stool from Home Depot,
Yeah.
or it could be a stack of books just to test it out. And or if you've got a really small bathroom in New York, you could try to put your feet up against the wall in front of you if there's a short enough space. But the idea of just elevating the legs when you're on the toilet, it relaxes that pelvic floor musculature. And you can speak to this better than I can, but I think that it makes it easier, and it reduces that feeling of need to strain. So those are simple things in the context of, I think generally, I think that I probably make those recommendations even when I'm not convinced that it's pelvic floor muscle dyssynergia, just because I think that it still helps, and there's sometimes a little bit of that, even if it's not the entire reason for their constipation, that still makes it easier for people to go to the bathroom. So those are some of the tricks. There's probably others.
I think it's so important that you send your patients to pelvic floor physical therapy, but for all of the patients listening and practitioners, can you explain why this integrative approach with having a gastroenterologist and a pelvic floor physical therapist and perhaps a urologist as well, or any practitioners that fit into the puzzle, why all of these components of healing pelvic pain is really so important, and that it doesn't just take one doctor to figure out the whole problem, but that it will most often take multiple doctors?
So I love the ability to collaborate in the management of my patients. It's often necessary, not always. I mean, there are certain conditions where, it just is simple and straightforward, and we manage the condition between myself and the patient, and that's really all that's necessary, and it's perfect. But I really enjoy the collaborative approach in the practice of medicine. I enjoy it professionally, just because I like to be able to talk to other professionals that manage the same conditions that I do, but in different ways, and I feel like we all learn from each other, and so it helps me to be the best physician that I can be. But I think, and so that I enjoy professionally, but I think for the patient's sake, that really, it optimizes their therapy exponentially when you allow other people to weigh in with their own expertise, towards bettering the health of my patient. And so I enjoy having, and I actually think it's very important, because the time spent and the therapy that a pelvic floor, muscle therapist can offer to my patient is entirely different than anything that I can do in my office. I can identify the problem and I can help manage in a way as a gastroenterologist as much as I can, but I can't spend the 45 minutes or an hour with a patient to really help them identify what the sensation is that they're not having that they should be able to find from a muscle control standpoint. Or I don't have the tools in my office, nor the expertise really, to be able to provide that kind of care. So I really think that it's not just a matter of my appreciation for the ability to share the care of my patients, but it's really in the patient's best interest to have available to them other practitioners that are experienced and dedicated to managing whatever it is that I'm treating. I mean, if in the context of pelvic health and pelvic pain and dyssynergia, then it's always going to be pelvic floor muscle therapy and pelvic pain management groups. And anything else that I'm managing, it'll be other types of physicians. It can be surgeons, it can be other subspecialists in the context of medicine that will help me to get my patient to where they need to go. That's the integrative approach in medicine. It's, when I think of integrative medicine, which is the way I really like to practice medicine, it's not, I think sometimes there's a misconception that integrative medicine, or it's confused with, I'm going to treat with natural herbs, and I'm going to use acupuncture. And I love all of those things when it's appropriate. My mind is open to that. But the integrative medicine that I practice is where the patient is in the center of my care, and we are focusing on making them well. So we are focusing on how we are going to heal the patient physically, medically, but also psychologically, emotionally, socially, because there are so many social aspects in pelvic pain, painful intercourse. I mean, that has significant, effects on their ability to have relationships, or, there are so many different work environments, and chronic pain interferes with people's ability to get through their days sometimes. So that's the integrative approach, is integrating the various different components of the management of my patient, and getting them not to the point where they're free of disease, because free of disease is not healthy. Healthy is when they feel well psychologically and emotionally and socially and obviously physically and biologically. So that's the integrative approach, and in the context of pelvic pain, because that's why we're here. That's one of the conditions that I find myself treating almost invariably, using a multidisciplinary approach.
Fantastic. Again, love to hear you say the integrative approach. I completely agree with you. Can we talk a bit about hemorrhoids? I get this question a lot from my patients. If you could tell us a bit about the difference between internal and external hemorrhoids, and how hemorrhoids would relate to pelvic pain itself.
Sure. It's always good to just jump right into hemorrhoids. Everybody wants to know about hemorrhoids, and a lot of times they don't really want to ask. It's often like sort of like an afterthought in the midst of a patient consultation. They'll come in complaining of something else, and then sort of just in like the passing, oh, by the way, I think I may have hemorrhoids, so hemorrhoids are really common. They are really not very complicated. They're really nothing more than just a dilated vein. They're like a varicose vein, but at the anal verge. Everybody has hemorrhoidal veins. We all do in this room. Everybody's got them. But they're not always engorged, and they're not always swollen. And it's when they get swollen, they become what we define as a hemorrhoid. And on the outside, they're kind of hard to miss. So they are veins that have become engorged, they're swollen, they are on the outside, they're visible, they're palpable, they're almost invariably very uncomfortable, and they can bleed. Sometimes they can bleed a lot, and it's very concerning to anybody who sees blood in the toilet or with a bowel movement. And they can make it uncomfortable to sit down. So I can sometimes pick up a patient who has a hemorrhoid even before they've said anything because they're sitting in my office off to the side, and so it hurts. So they're very painful. And an internal hemorrhoid is almost the same thing, but on the inside. And those tend to be a little bit harder to be aware of symptomatically, except if they bleed, or sometimes they can itch or just be a little bit uncomfortable. So the internal hemorrhoids, patients don't realize are hemorrhoids because they immediately associate a hemorrhoid with something painful, but they're usually not painful, but they can bleed quite a bit. What causes a hemorrhoid? It's a long list of things. Sometimes there's just some patients that are just predisposed for whatever reason to developing hemorrhoids. But in the context of pelvic health and constipation and pelvic pain, often straining, bearing down. That's why women will often develop hemorrhoids during childbirth, because they're bearing down so hard to push the baby out, and they are engorging those veins and they will swell. But people end up doing something maybe not to that extent, but similar when they're bearing down and straining against pelvic floor dyssynergia, or for any other reason that they're feeling constipated, and they're pushing and pushing, and lo and behold, they develop a hemorrhoid, which sometimes then complicates their constipation because now they've got pain, and nobody wants to feel pain and when they anticipate it in the context of a bowel movement. So sometimes it actually then makes patients feel a little bit more hesitant about wanting to have a bowel movement, or sort of fearing, or the pain that's going to be associated when they pass the stool. So it creates a little bit of a vicious cycle, unfortunately, in the treatment of constipation. So you have to treat the hemorrhoids. They're treated conservatively, very similarly. Topical steroids, sometimes if they're necessary, topical analgesics to help take away the pain, soaking in a bath, sometimes an ice pack, depending on where you're at in the life cycle of that hemorrhoid. Trying not to put too much pressure on the area, sitting on a donut, or just not spending too much time sitting or standing or bearing down. And that's often enough, it really is, and just try to minimize the reasons why the person developed the hemorrhoid. But once we get past that point and they become a recurrent problem, they can be painful, and they are in the pelvic region. And the withholding of stool to not reproduce the pain creates pelvic pain, and there's anal pain. And so then I often will then integrate my management with a colorectal surgeon who's experienced in managing hemorrhoids. And there are various ways that we can more definitively treat hemorrhoids when the conservative therapies aren't enough.
Great. So I really wanted to touch on SIBO, and what are your thoughts on the connection with SIBO and other GI infections with pelvic pain and pelvic floor muscle dysfunction?
Sure. Well, I see SIBO often, and I don't know if we're seeing SIBO more often now because we're thinking of it more often, and so we have better assays to be able to test for it. So because we can define it a little bit better, I think it's becoming a bit more common. Probably been there all along and we just didn't know it. But so I do see SIBO often in my practice. And SIBO is the acronym for small intestinal bacterial overgrowth, which is essentially what it sounds like. It's an overgrowth of bacteria in the small intestine for less than simple reasons. I mean, it's a simple name for very complicated reasons, not always as easy to define, that there's an imbalance, there's a dysbiosis of good and bad bacteria in the gut. And I think that as time goes on, we're going to understand this better and better, and it's going to be a phenomenal explosion in our understanding of medicine and why people suffer with so many of the conditions that we do. But symptomatically, the way that SIBO presents often, one of the hallmark symptoms that I see is gas and bloating. Mm-hmm. And that's one of the things that makes me think of it, and one of the things that makes me test for it and then treat it. And so gas and bloating is a tough symptom to really define clearly. It's so nonspecific. There are just so many reasons why a person may feel that way. And it's probably one of the most common symptoms that patients will come in, complaints that patients will come in with. And it very often tends to rest kind of in this lower abdominal area. And that's that gray zone between the abdomen and the pelvis. And so when you have, and to take it a step further, probably one of the most exquisite pains that people experience in their abdomen/pelvis is gas, because it's stretch, and your bowel is extremely sensitive to the pain associated with stretch. It's funny because there are certain types of pain in the bowel that you really can't feel. You don't feel burning sensations inside the intestines, just the way we're wired. But stretch you do. And stretch tends to come from either constipation, where there's just volume and pressure, or gas. And that's why gas pain can be so awfully uncomfortable, and it tends to be in the lower area. And so patients will come in complaining of pelvic pain associated with bloating, and it takes you on that initial diagnostic trip of, let me make sure I understand all the things that this is or this isn't, particularly in women. If there's bloating, even if it's related to SIBO, I've got to make sure that I'm not missing a gynecologic malignancy, like an ovarian cancer or something that you would really never want to miss. And so symptomatically, SIBO presents in a way that so many other conditions do, that we need to differentiate SIBO from. And but once we go through that diagnostic process, it is, I think, probably one of the more common explanations for the discomfort that patients will end up coming in with.
Can you tell us a little about the diagnosis and treatment of
Sure.
SIBO?
So we used to treat SIBO empirically. It was based on somewhat of a diagnosis of exclusion, a clinical symptomatology that made sense, that fit, and we didn't have, when I first went into practice, we didn't have a readily available assay that would allow me to define whether or not a person actually had SIBO, but we had a treatment for what had been used to treat what we assumed was SIBO that seemed to work pretty well. But over the past several years, it's become much easier to make that diagnosis. And so the way that I make the diagnosis of SIBO is using a breath test. It's a hydrogen methane breath test. It's a little bit labor intensive in that it takes a little over an hour, but it's nothing more than having a patient just blow a series of times at set intervals into little tubes that we send off to a lab, and then the lab uses a machine that assesses their breath, the air that they've put into these special collection containers, and it measures at each time point the amount of hydrogen gas and methane gas in the patient's breath. And we tend to use either the reference point of elevation above their baseline, or just elevation above a certain point that's considered normal, to define whether or not there's an overgrowth of bacteria in their small intestine or not.
Great.
And the treatment, there's many treatments for SIBO, and I think that's still in evolution. One of the mainstays of treatment has been a medication called rifaximin, which is an antibiotic. It's a non-absorbable antibiotic, so it just really stays in the gut. Tends to have reasonably good efficacy in the management of the symptoms and the treatment of SIBO. But there are undoubtedly so many other ways that SIBO can be treated. I think diet plays a very, very important role in how we treat SIBO. There are certainly some natural supplements and protocols that have been put out there for the management of SIBO that I think are worth considering. And I think it's a work in progress. I really do.
And also, can we touch on the brain-gut connection, that whole phenomenon? Do you mind discussing that a little bit and how we should approach it?
Wholeheartedly.
Yeah.
I do. I think chemically, there are neurotransmitters and that we have recognized and we've been aware of for a really long time that are shared between the brain and the gut. So I believe wholeheartedly in the brain-gut connection. I always have. I believe in it not only because medically we've been able to define it and we have objective evidence that in fact there are connections, neurotransmitters and chemicals that are shared between the brain and the gut that have a tremendous influence on the way that people feel. But clinically, just in my experience, every single day in my office, the relationship that I see between how a person is feeling emotionally, psychologically, stressors that are going on in their life, and the effects that these stressors have in my world on their gut. And I'm sure that there are other ways that psychological, emotional stress affects people somatically. I'm sure they There are reasons why maybe that may also trigger migraines or tightness in muscles or neck pain or all sorts of other things. But from a gastroenterology standpoint, and I think it really happens to be probably one of the most common places that the brain will settle its stress or worry is in the gut. Part of the reason why I have a hard time seeing patients in a short period of time, like I can't see a patient in my office quickly, 1, 2, 3. It doesn't matter how simple of a reason it is that the patient may be there. I like to spend a solid 30 minutes with my patients because it at least, sometimes it ends up being a little bit more because it's so important for me to understand where they're coming from. It's not just my stomach hurts or I'm having diarrhea or I'm constipated or I'm nauseous or my Crohn's disease is flaring. And I obviously know I need all of that information. I'm a medical doctor and that's what I do. But I can't manage that patient without understanding what else is going on in their life. Are they working 90 hours a week? Did they just change jobs? Did they just have a baby? Is there a family member who's really sick? Is there something going on that is just as important in the management of their overall sense of well-being that I need to identify in order to be able to help them to feel better? It's not always just take this pill or have this test and we'll get you better. And the reason that I do that and the reason why that's important to me is not only because it's important to me to establish a relationship with my patients, which it is, but because I believe completely in the brain-gut connection. And I believe that the stressors that people are experiencing or even the happy stressors, they don't always have to be all negative, play a very significant role in their GI health.
Something I read recently that I found fascinating was that 99% of your immune system is based in your gut.
Yeah.
And as a patient who's had chronic GI issues and pelvic floor issues, I've really realized the importance of figuring out what's going on in your gut and really finding a way to heal your gut issues, because if you can heal that, with that, so many other issues will resolve as well.
I agree with you completely. Mm-hmm. And I think that even to take that even a step further, and I don't just say that because I'm a gastroenterologist, but I am one, and that's probably why I believe it more, because I spend so much time thinking about it. But I think that when you think about that for a minute, and that's why I think that our understanding of the human microbiome, which entirely fascinates me, is going to be one of the greatest frontiers that we are going to enter into in medicine, that I think is going to help us understand so much of the things that we don't yet understand well enough in medicine. It's the microbiome. But when you stop and think about that for a minute, I think that underscores, entirely reinforces something else that I believe in very much so, which is the way that we eat and the things that we eat and the food that we put into our mouth and like where that goes, because it's going into our guts, and it is going to be processed in ways that may be great or not so great, and it's going to leave byproducts in ways that may be great or not so great. And so I think that to that end, spending time understanding what people are eating and how they're eating and making an effort to eat healthfully without even having to follow necessarily a fad diet, or sometimes they're helpful, but just in general, making healthy choices and listening to our bodies, I think will have very, very, very beneficial effects, not just on gut health, but on everything else, on patients' skin, on their emotional sense of well-being, on their ability to sleep well. Everybody always feels better when their stomach feels better, and nobody feels well when their stomach hurts. Mm-hmm. So I agree with that, and I think that it's fascinating, and I think it's going to probably, we're going to get to understand that better and better, hopefully in the near future.
Mm-hmm. As a gastroenterologist who specializes in women's health, and as we've spoken about, you see a lot of women who have pelvic floor pain. Many people listening, I'm sure, who have pelvic pain have an overlap of GI issues as well. So what would be one word of advice that you can recommend to the audience?
I think one of the things that I find often that if I have the opportunity to tell patients ahead of time, I would like to be able to, is not to suffer in silence, not to, sometimes these are embarrassing symptoms to talk about vaginal pain or anal pain or pelvic pain or pain during intercourse, or hemorrhoids. They're sensitive subjects. Even discussing their bowel habits, sometimes patients come in and they are uncomfortable to be able to say that it's not a conversation topic that most people are at ease with. And it's amazing. I think that it would make it a lot easier if people knew that so many other people are suffering with very similar symptoms, and that there are symptoms that are very easy to talk about with a gastroenterologist or with a medical practitioner that understands why they might be experiencing these symptoms, and that there are so many treatments available to help them to feel better so that they don't need to live their lives suffering with pain or discomfort or in any way not feeling as well as they could or they should be.
Wonderful. And where can people contact you?
I'm in private practice on the Upper East Side. I'm on 1317 3rd Avenue. I have a website, Bonheur MD, my name, md.com, and I'm available.
Great. Thank you so much for being here and for sharing all of this amazing information.
Thank you.
And if anyone has any other questions for Dr. Bonheur, we'll link all of her information so that you can easily contact her. Thank you.
Thanks so much for having me.
Thank you.
Thank you for tuning in. If you can relate to this video, please leave a comment below and share this with anyone else who you think may benefit. Thank you.